All right, got a couple of things to get through today, and I'm flying solo on the chairing duties. If anybody would be willing to put up their hands to take notes for today, that would be super helpful.
Yeah, that'll be me, Michael Osborne.
Brilliant. Thanks, Michael.
Thank you, Michael.
Excellent. All right, so let's have a look at the agenda for today. All right, so we've got the usual business. We'll cover that. Then we've got a couple of sessions from Andy Bond. He's going to be talking about additional features, prioritisation, IG design principles. Then I will be talking about eRequesting actors. This is a bit of a, I guess, bringing together some ideas that we've shared in different ways in the past, just for a bit of open discussion to formalise, maybe not formalise, but agree on some names around things. Then Andy's going to come back and talk about the scaffold branch design options, and then we'll have a look at the next meeting. So that should be a pretty full day, I think. All right, so let's get the usual business out of the way. We need to approve the meetings for the 5th of the 9th. So let's bring that up. Okay, so these are the meeting agenda and minutes from the 5th of the 9th. Assuming those are all correct, would anyone like to move that we accept those?
I'll move, Michael.
Thanks, Michael. Somebody second?
I'll second, Chris.
Great, thanks guys. All right, let's take a quick vote, get this one out of the way. Could everybody who approves those minutes please raise your hand? We have 16 of 37. All right, 16 of 37. You can put your hands back down, thanks very much. Just because that's quite on the edge there. Does anybody wish to reject approving the minutes? If so, just raise your hand. Hands are on, your hands are up. Nope. Okay, so I'm going to count that as 16-4 and the remainder abstaining. Okay, motion is approved. Thanks very much. Meeting minutes from 30th of April are still to be finalised. That is my fault. I haven't updated the names on them. I apologise. I will do that for the next meeting. All right. So we had an action here that is listed here, Angus and David, to resolve a query on task. Sorry, I've got the screen.
Yeah, I think I can speak
Task owner for the scaffold and bring to the team on the 28th of March. Yep, great.
So I think I can answer that, and happy for David to talk if he's here. I'm not sure if he's here. So we definitely spoke about it. So we were talking about the owner of task, and the question was, at the moment, the owner is an organisation, that being the FHIR organisation for the eRequest, so a Sonic or a Helios, or whoever that is. And we were just discussing whether at this stage we needed to open owner up to other individuals such as practitioners and any other options like device, but mainly practitioner was the questions, or practitioner role even. But I think we came to a consensus that my view is, whilst we're not dismissing that in the longer term future, tasks could be assigned to individuals like a practitioner role, at this stage for release 1 for diagnostic imaging and pathology, we couldn't see a good reason to do it now. We think task ownership by an organisation suffices what we need to do for this use case. not to dismiss that some latter down the road use case may open it up for practitioners or practitioner role in the future, which was what David's point was. So I think we've, unless David wants to yell otherwise, I think we'd resolve that we're quite happy with where it is at the moment in the scaffold, that task owner is an organisation. Unless anyone else wants to object to that. I assume David's not here.
Does anyone have any thoughts or comments on that they'd like to share? Task owner is an organisation. Steph?
Yeah, just wondering if, I mean, I'm sure it's already been considered, a healthcare service, particularly where it's in the hospital setting, or, for example, my previous project working on defence health, the organisation would be like defence or the hospital itself, and it's necessary to track the task ownership down to the healthcare service line.
Yeah, I don't dismiss that either. I know there was I think it was on Zulip, Heath had raised, no, it was actually a AU core issue raised with their balloting as to clarity around whether to use organisation or healthcare services, when to use one, when to use the other, which hasn't been resolved. So I'm not against the notion of healthcare service. I guess I'm happy to discuss, would a radiology clinic be represented as a healthcare service, and would a pathology organisation be represented as one? That's not what we've done yet. And I think it's a wider conversation when you talk about practitioner role, the whole chain of practitioner role at an organisation with a practitioner, whether you use a healthcare service in that structure or an organisation is difficult. Patients managing organisation is an organisation, not a healthcare service, which complicates the matter, which is probably why they've leaned towards organisation. I guess my point still stands that I think organisation is where we're at now. And if people want to put through a strong case to say we should also support some other owner, then I'm not against it. I just don't know the strong use case to do it yet. We're in the early phases, and I feel organisation serves the purpose, but I'm not dismissing a use case. I just don't know of the use case to use anything beyond organisation. I'm not disagreeing with healthcare service.
Yeah, totally agree. Yep.
Yeah.
Yep. That the use of organisation seems to work well for the primary care setting. And yeah, whether we need to consider some flexibility in supporting healthcare service as well for other settings. Yeah, that requires some more discussion.
I guess and you may be that person. I'm sort of waiting for someone to plead the strong case as to why organisation does not work, in this case. And if we can find that, I have no objections to also using healthcare service. I just don't want to add stuff in without a valid reason to start with. And practitioner role to me falls into the same category. I'm not against it. I'm just don't have the strong advocate to say organisation absolutely doesn't work, and therefore I need this.
Yep, understand.
Andy?
The current scaffold has the 3. So it's got healthcare service, organisation and practitioner role. The organisation is mostly there to carry the identity of an organisation, but it doesn't preclude identifying a hierarchy of organizations. So you could have an organization which is part of another organization, which is part of another organization. But mostly it's for the purpose of request discovery, for the filler to have an identifiable role as the filler. If there are other aspects of fulfillment that need to be set within that owner, then yeah, I think that there is a discussion around that. So should I, in the scaffold, restrict it to only organisation?
Look, David's concern, I think, was stemming from the notion of a directed request, which is a concept that can be, it's rare, but can happen, where a pathology order is directed to Dr. John Smith at this pathology organisation. He was kind of concerned about that use case. In my view, I was thinking it's a valid use case, but it's not in the 80%. It's a down the road sort of thing. Should you get rid of the others? It doesn't bother me. As you said, we're using it currently to identify tasks that are owned by us. So we say where task.owner identifier equals our HPIO. If that returns nothing, then there's no task for us. I'm not concerned if task owners have other things like healthcare services or practitioner roles, because they don't affect my use case of trying to find my tasks. And I just don't have a use case from where I sit for a task to be owned by an individual or a healthcare service, but others may. And I guess it doesn't affect my use case if other tasks have other owners. It just starts fanning out into what are those use cases? Are we going to go down that avenue, fleshing out what they are? Do we need
That's
to
fine.
for release one?
I'll just leave it in those three. The only issue with health service at the moment is I don't believe there is an AU core profile.
The healthcare service, yeah.
So we're back to the base, AU base profile for health service.
I mean, I guess it doesn't hurt to leave them there. I just hesitate going down, unless we have strong reasons, going further down the road. Like, I'm happy that someone may have some use case to use it, but are we going to walk down the road of what that use case is and how that affects other things? I don't think so at this stage.
I'll just put some commentary in that initially we're aiming at organisation, and the other two are there as placeholders for future use.
Seems sensible to me. But at this point,
An
since
action for you, Andy?
You're on mute,
Yes.
Andy. Yes, I think he's saying the action.
Yes, yes. Why not? Why not an action for me, Michael? First up.
Michael, did you have something you wanted to say?
No, I was just trying to clarify if that was an action.
All right. Okay. All right. Are we all resolved on that one then?
I think so. And I think for now, and also another point here is like, why is this suddenly called out as this important thing we have to solve now? We have many properties to walk through the resources, and we will circle back on task owner when we walk down each resource, and we can reassess then. So that was my other angle as to, I'm not sure why this suddenly became the most important thing that we had to have a breakout group to talk about. So I'm more than welcome that as we walk through all the properties on task, that this is reassessed at that point in time as well.
Sure. So I guess it's worth reiterating then that the way in which we're trying to solve issues relating to those questions is to deal with them when we walk through them, rather than in any other kind of ad hoc fashion unless they're super critical. That be accurate?
Yeah, I think so. I think we've got an agenda where we're walking through groupings at the moment, and that's the top topic, and we'll eventually come around to all the other properties as well.
Yep. Okay, great. Thank you. Andy, are you ready to talk about additional features prioritization?
Sure, I can do that. Do you want me to share my screen?
Yeah, you can if you like.
Peter? Alrighty, these are the current votes. We're still looking, I think, at the grouping as the current top dog. The communication with patient not featuring highly at the moment. Communication with placer got a fair bit of interest, but not as high as my health record upload consent. Some of these have a fair bit of commentary. Copy to another practitioner, which needs a further discussion. Claiming in order, which is pretty important optics on that. And the rest of them, I don't think are featuring extremely strongly. So we've had no new commentary. If anyone does have additional features that they want to add to this list, feel free to do so. I will attempt to take some time this week to triage through the commentary to make sure we're actively supporting those additional perspectives in the discussion we do have. Is there any questions on the additional features? Nope. Okay. Do you just want me to go on to the design principles?
Yes, please.
Alrighty, design principles. We're just doing a quick recap of this to make sure everyone is aware of them. These are a draft. They are there to be have things thrown at them. As Danielle has demonstrated, please put some commentary around these if you do have issues or suggestions on how to better change them. We're trying to at least expand these as we go. So if we are coming up with foundational reasons why we approach things in certain ways, we want to make sure we have a reflection point in these design principles. I think that patient-centric was the last one I added in. Again, if you have any commentary, please just, even one word, stick it in the comments at the bottom, and we'll attempt to make modifications or add new commentary or new design principles as you suggest. The agenda. What was next, Chris?
Next is eRequesting actors.
Excellent. I'll stop sharing.
Yes.
Oh, can I just do one update before I go?
Yeah.
Just to say that I have added into the data model, you'll see that some of these FHIR elements now have references. So as I said, I think the other week, I was going to go through and link these to the scaffold. So if you are curious about how some of these elements map into the scaffold, those which were obvious at the time I was doing this, I added a link in. A fair few of them are covered off. Some of them still need to be done, but it should give you a good starting point if you're looking at having a better understanding of what the proposed approach was, or a suggested approach, as part of our work. That was it, Chris.
Yep, back to me. All right, thanks, Andy. I'm going to have a little chat about eRequesting actors. So what is eRequesting actors, and why are we talking about this right now? Well, essentially an actor is the name with which we are labeling a particular person or role or system within this discussion we're having around eRequesting. And this came out of looking at the list of R1 use cases and realizing that there were a whole lot of different things listed there that were kind of the same, and maybe some things that were the same but were listed differently. And this is really just a discussion around clarifying what the terminology is around actors, and then extending that a little bit, since we're talking about actors, with use cases in the form of very simple UML diagrams. So what I've attempted to do here is capture at a very high level the UML use cases that are expressed through the R1 use cases list. So it's not exhaustive, it's not highly detailed, it doesn't go down as deeply as many of those do, but hopefully it gives us enough to ensure we're all on the same page around those things, and start the discussion around what those names are going to be. Now, I think this should be a relatively uncontroversial topic. I don't think it will take us very long to get through, but this is the starting point, and we can go from here. So, like I said, there are lots of use cases, but most of them are the same. For example, if you are sending a directed request or creating a general request, as far as I'm concerned, that's the same use case. For a practitioner, they just want to create a request. Now, we might talk about more implementation details that differentiate how that behaves, but ultimately the use case here is potentially the same. Now, I could be wrong about that, and if you think otherwise, now is a really good time to have that discussion. Notably, that won't change, I think, it really significantly how it ends up getting implemented. It's more about understanding. So what I'm presenting here is not final, it's just a representation of what we're doing. Use cases are never really final, they're too vague. So the questions are how this helps us understand what our collective goals are and understanding what we're doing. All right, so I'm going to go through 3 actors primarily. The first one, which seems the most obvious since we're talking about requesting, is what I have labeled a practitioner. This is the most common name with which it is referred to in the use cases. It is also known as a requesting practitioner, a GP, potentially a hospital or a specialist. In any case, it's usually used to indicate the individual who is making the request, but it is not always the individual who is making the request. And this, Angus, does somewhat come back to the discussion you were having before around when is it an organization, when is it someone else? So a practitioner can kind of do 5 things. They can request diagnostic imaging, they can request a pathology test, they can also request an INR test as far as our model goes. Yeah, Andy.
You knew this wasn't going to be easy. When you, I guess just to note that while you use the term practitioner, there is, I guess, an overlay into FHIR, and we are expecting that the request is actually made more from the role of a practitioner role perspective rather than a practitioner. The reason I raise that is that the practitioner is not creating that order as an independent party, is my assumption, and that they're doing so as part of an organisation. Angus, you can say disagree with that, but it may be what you're implying, and obviously covering both the clinical individual as well as the administrative staff, as you said, that might actually be raising that request on behalf of a practitioner belonging to an organisation.
Yes, and that actually raises an issue that I encountered when attempting to define these, and that is the roles that systems play in this model. So I think I've gone with a very basic initial actor here, without trying to define too tightly what that actor actually represents. But that is essentially what the use cases had defined. But otherwise, I agree with you.
I'd be interested from a policy perspective whether an individual can actually raise a pathology or diagnostic imaging request, or whether it is, and what's the relationship to the organisation. It may be a bit of a academic question, but it actually comes to ultimately what it means then to produce the report and where the report goes.
Mm-hmm. Okay. I've taken a note of that.
Maybe someone from a department can provide some insight into that, or the college.
Yep. David, you had your hand up next.
Yeah, I think sort of overlapping. I'm not sure that a hospital can raise a request. I think it still has to be a medical practitioner in the employ of the hospital. So someone's name needs to be on, like a doctor's name or a nurse practitioner's name needs to be on the request. Mm-hmm. And along with that, my understanding is it also has to go along with a Medicare provider number. That's my understanding. It would be incorrect, but that's my understanding.
So that would imply the organisation, as part of that Medicare provider number, is kind of mandatory part of the order.
Well, not necessarily. So a provider number is associated with an address. So it's not associated with an organisation per se, which can be problematic if you think about a hospital that's got potentially, say, all at one address. You might have, say, a pharmacy on site that's managed by a separate legal entity to the owner or manager of the hospital, and maybe a pathology service, which again might be a different legal entity to the local area health service that runs the hospital. But they're all co-located at one address. So the provider number doesn't necessarily imply an particular organisation, but you do need to associate a provider number with an address.
Lots of hands up. I'm going to move to the next one that I can see. Michael Wilson.
Oh yeah, I think you kind of hinted at a little bit before. Eventually, we will need to get these down to system actors as well for the implementation guide, because the actors have a relationship to things like must support obligations and capability statements and the like. So yeah, we will have to take these to system actors at some point in the future as well.
I had a slide at the end, which we can come back to on that if you like.
Yeah, okay.
Bharti?
I think just second to what Angus was saying, that it's more of a practitioner role because that gives you more information about the provider number and the location. You can set as an address or an organization, because being a practitioner, you could be, practicing at 5 different places, but when you're placing the order, how would you know to which location or which address you are ordering it from. So just wanted to add to that.
Yep. Thank you.
Thank you.
Angus?
Just add, I've got the Medicare schedule open. So for requesting practitioner, you need a name. It just says the word name, and a practice address or provider number, not and. The other point I was going to add is we commonly use placer and filler. Not saying they're awesome terms, but all through the previous standards building for ordering, we've always referred to placer and filler. So in this case, that'd be the placer. And the last point I'd make is from Sonic Healthcare's point of view, everything hinges on the provider number. That's the key identifier we use to identify the person placing the order.
Yep. Good feedback on placer and filler, I think, because they're not defined in the use cases. So that a next step might be to look at that as well. Dan.
Yeah, just echoing some of those comments and adding that we do experience practitioners using the same provider number, rightly or wrongly, across multiple locations, just to make their job easier.
We have that fun as well. I agree with that one.
Mitish.
So, with e-orders or from referring doctors, especially from hospitals and different wards, we sometimes have that the doctor who is creating the request does not have a provider number. So what they do is they actually use superiors. I cannot remember the term, but I think it's ordering provider.
Consultant. Yeah.
Yeah, consultant. They would use their superior's provider number, which will be sent in all e-orders. So as Angus said, that provider number links to a lot of other channels with results delivery and all those things for matches. So it is very important to have that.
Yep. Okay, great. Thanks, Mitish. Rosemary.
Yeah, I was carrying on from Mitish's. I think what Mitish is referring to is ordering on behalf of, which is probably something that we do need to cover there. So if you're not a practitioner that doesn't have a provider number, you still require the means to order on. So, and also the other thing that I was trying to raise was what occurs in the places where it's not a Medicare billable instance that the practitioner is requesting the pathology on behalf of pathology for, or even the radiology. So, for example, work cover or a commercial agreement of some sort. How are we covering that, or do we need to cover that?
I think we're slipping into how do we identify the orderer, like,
yep.
which is a big topic.
Yes, agreed, definitely.
Yep. Okay. What we're trying to get to at the moment is what do we call the orderer? Once we've worked out what that is, then we can work out how to identify them. But that's agreed, and I've noted that as well. Thank you. Jojo.
Hi. Yeah, just touching on the same point as well. Within the ACT territories EPIC electronic medical system, we have ordering clinician for pathology and also the authorizing or the requesting clinician. So the ordering clinician could be a JMO, a VMO, consultant, someone who doesn't necessarily have the pathology authorizing rights, but they can order, but there has to be co-signed. So that's a different model. This is really only posed in the sort of an inpatient model, obviously, within a hospital setting, but that is something to consider as well.
Thank you. Angus?
I was going to say it's where placer, I think, has worked in the past because it's not trying to say even a human you can have blood gas machines creating orders in hospitals because someone went up and used them. So just reiterating that whilst we still have to get down to how do we identify the entity placing the order, if you want to just talk about the reiterating that placer is this sort of very agnostic term. It's not trying to say who that entity is at all.
Yep. I guess if we're going to talk about places, then we need to start asking who can cancel, who can track.
Places can cancel, places can track.
I'm not sure I agree with you, but I'm not going to have that discussion right now. I'd like to break it out a bit more.
If we're touching on cancelling a service, is there also are we going to the level of detail? Is it able to cancel after it's ordered, or if the specimen's been received, can they still cancel the request?
We have not had a discussion around when a request can be cancelled.
Thank you.
So certainly, in the pathology sense, once we've collected the samples, it can't be cancelled. But it's another offshoot discussion.
Yeah.
There's also an issue with paper in play as well. Once a piece of paper is out in the wild, is there any cancellation even possible?
Just in a naming sense, it's for me, it's how human friendly do you want to be as to how technical and abstract. Like places, I agree. Like place of filler, it can be confusing because it's so abstract, and then you can humanize it. You can say doctor, clinician, practitioner, which is more humanized, but then possibly has edge cases where it's doesn't make sense. But in the 80%, it does make sense. So it's kind of a decision of where along the abstractness do you put this to make it human friendly enough. But there's always going to be edge cases where they go, well, it's not really a practitioner because it was a machine that did the device, did the order. But do we accept that in the 80% people accept that a practitioner, doctor, clinician makes sense, even though there are edge cases where it may not be them. So to me, it's about how friendly a term do we want to have, or how abstract.
Yep. Agreed. Thank you. On that note, let's move on to the next one. Service provider, or as we might also call it, a filler. We've kind of defined two of these. We've defined diagnostic imaging and pathology as separate service providers. I'm not sure that's necessary for the purposes of a use case, though it might be necessary for the purpose of how we structure a request. I guess one question might be, at what point when we start touching on workflows more deeply, do they start to split apart and have different use case requirements? Anyway, service provider, from what I can tell from the use cases we've defined, can do four things. They can access a service request. They can claim a service request. We haven't really defined what that is, but we've certainly said that they can do it. They can update the status of a request, fulfillment, and they can cancel a request. Those are the only four use cases I could actually find in the use cases that we had. Noting what we already know around provider numbers and places and fillers. Does this raise any other questions for anyone?
I guess I'd ask, like we had touched on the conversation with identifying practitioners, like provider numbers. Do people have views as to, is it easier here? Is a HPIO a solid thing that everyone would use, or is it not that clear to identify service providers. And this kind of goes back to that task owner conversation about, is it an organization? Is it a healthcare facility? Is it a practitioner role?
Philip?
So I'm probably not going to give the answer you were hoping for there. I was just going to highlight that, the service provider, we need to make sure that we're covering for the scenario where the service provider is not done or not known, right? Where the patient has the absolute choice of where they would like to go in the scenario too. So I guess today, when I put to try and answer the question you asked, when I put the hospital hat on, generally the patient is getting a requisition that they could take anywhere. I can't think of any of my clients that have the named pathologist or the named radiologist or the named service that they are printing. And most of the time that's going to go into the hospital's, pathology or radiology because it's convenient because you just walk down the hallway or whatever. But technically, in my experience, at least in the hospital side, it's on a letterhead where technically the patient could take it then to any private pathology, any private radiology, even if that's not the one that is physically co-located with the hospital.
Yeah, and I think I've deliberately actually avoided the idea of assigning a request in these use cases. And that's not because I necessarily think that it should be either way, but I think the act of assigning a request is undefined in our system at the moment. And that comes down to the way in which repositories are undefined. So we haven't talked about how a repository should work and what a repository should allow. What kind of queries should a repository allow? What kind of data should a repository allow? And how should that be accessible? And to the extent to which a request can be assigned means kind of one of two things. It means either that the request is labeled in such a way that a service provider knows it's theirs, and secondly, that it's actually been sent to them. Now, the latter is much easier since it doesn't actually require any particular FHIR labeling in any particular way. It just requires it to appear in their system. The former is somewhat more complex depending on how repositories are defined. So I guess I've left it out of this and just gone, we can create the practitioner wants to create a diagnostic request. And that's the limit of that use case for now. Angus?
I was just going to show our hand and say Sonic doesn't support undirected requests. All requests, in our view, should be assigned to a provider.
I feel like it needs a discussion around what is that and how it works and what does a repository look like. I think that's the big thing, because the limits on what a repository can do are going to define how that can be implemented.
No, I also think at a standard level, I can accept that there is a concept of a 0 to 1 of assignment, but just showing our hand early that we wouldn't entertain a repository that supports unassigned requests.
Mitesh?
Just adding to Angus. So if we have a request with, say, for example, no provider or the practitioner details, how do we know where I know we are not covering results delivery as part of this at the moment as eRequesting, but eventually for directing the results back to the referring doctor, if we don't know how we can identify them, how the results will go. And also in hospitals, it may work because they all have the EMR in use, so everything stays there. But if it's outside hospitals, then it becomes a big question.
Sorry, could I just clarify what you mean there? You get requests that have no doctor associated with them?
No, so if we had a request with no doctor associated, how would we know that we need to send results via this delivery method to a particular referring doctor? That's what I'm trying to mention. I know we are not covering results delivery as part of this, but that's where identifying a practitioner becomes very important.
I don't think, Mitesh, we're entertaining the actioning of a request that is not assigned to someone. It's just the notion of a request having a life cycle where it's unassigned to someone, but at late binding, like so at the time they come to your radiology clinic or your collection center, it is then assigned to you. So you now know, oh, sorry, I'm confused. Sorry, we're talking about service provider, aren't we?
Correct.
Sorry, I take it all back. Yes, I don't know how we can have a request not requested by someone.
Absolutely.
I think that's a requirement. Yep. Jojo.
Oh, sorry, I just wanted to touch on Angus's point. Just want to understand your current state. Do you mean that you have to send include a service provider in your request on every pathology request that's generated, or any request that's generated?
So it's just the notion that when a request is created by a doctor, that it be assigned to a provider, not a brown paper request that just floats around waiting for the patient to arrive. So we 100% support patients' choice to go wherever they like, but we believe requests, when created, should be through consultation with the doctor. A provider should be chosen.
And that's just part of your system design, and the way that's been built, that it wants to capture that field and needs that field in order for a valid request to be processed. Correct?
It's not really about system design. It's more of a policy decision, or I don't know if it's a policy, or it's our view. Like we don't support the notion of there being pathology or radiology requests which live unassigned.
Unassigned, yeah. Thank you.
But except in a hospital, except there's workflows where that, in a hospital, fine. It's more our organisation's view.
Dan.
Yeah, so I'm just thinking that through. Shouldn't the assignment be done upon accepting of the request?
Not in our view.
No. Okay. Can I park this discussion on the politics of assignment, because I feel like this is off topic, and while I think it's a valuable thing to discuss, and probably the discussion needs to be had, this might not be quite the right time to do it.
Is it worth standing up an unassigned as a valid value? So I noticed that what Angus was saying previously, that he has to assign someone, but if the clinician decides that they're not going to have to select a service provider, is it worth supporting a unassigned as an accepted?
I think at this point we haven't come to an opinion on that, but ultimately we'll probably have to support it, would be my personal view. Andy?
Well, I was just going to say, keep putting your hand up and take it down again. It's just to keep in mind that we are talking about a system where paper and digital are expected to live together and, in fact, be used together. And so we do need to, given the timeframes we're looking at, and R1 is to look at something which is able to work alongside the existing paper business models. And so I think we should be driven by that without unnecessarily constraining the future. And I think, as Angus pointed out, there is every opportunity to make that ownership a kind of optional attribute, but the reality of implementation, given paper and how paper is currently used, that it is something where we would imagine that most implementations would choose to make consistency between that paper and digital form. And if it's going through a branded piece of paper when you're doing the order, then it's likely that that same mechanism would carry over into the digital world at this point in time. But I don't think there is any, at the moment, call by anyone to constrain out the option of there not being assignment. It's just the reality of it actually being used.
Thanks, Andy. Philip?
I agree with the principle that you have there, Andy, on that thought process. And Angus definitely gave me the out that he acknowledges that hospitals are a bit different. I think my challenge is that if we go so far down a design that has been constrained by the workflows that we see in private practice and GPs and specialists, then retrofitting it later on for the hospitals can be quite difficult. That's been my personal experience with things like e-prescribing, where there are significant workflow differences around that. So we don't have to make a decision today. I'm not trying to propose that, but I guess what I'm thinking is that even under the thought process, Andy, you're proposing here of we need to keep the paper still going in parallel, at least from everything that I've seen from our clients in the hospital space, that piece of paper is often not on a branded form. And so we need to figure out, are we going to say that there is a default assignment made to the hospital's chosen provider? Or are we going to recognize that there will be some unbranded pieces of paper flying around, at least from hospitals? And that we should be thinking about that from the get-go here too, because if we don't, we may paint ourselves into a corner. That's my concern.
Yep, that's all valid. I'm going to pass over to Jai briefly. I think the key thing here is that the TDG co-chairs need to go away and work out a process for discussing this, because this is probably not a discussion we can resolve today. Jai.
Yeah, I was going to say the same thing. I think we need to certainly box it and look at a separate session to sort of unpack this. I think from the department's perspective, though, unassigned does need to be supported in the patient choice world. So there will be situations where the patient won't have made a decision leaving a doctor's surgery, or perhaps in hospitals in a similar way, and it won't be assigned until someone has received it and picked it up, whether that's in a open world or whatever that looks like in the future. But I think we need to have a broader conversation around that outside of the session.
Yep, thanks, Jai. Okay, so the action item for the TDG is to go away and work that through. Sam, did you have a short comment you wanted to make? We're just running a little short on time.
Yes, in this scenario, I cannot see any interaction between provider or practitioner with results. So is that something that discussed separately? Because interaction with result might be one of the important part as well. That's my question.
Yeah, it's an absolutely critical part, but unfortunately it's not part of the scope of the eRequesting project. So locating places in the use cases where we are not doing things is also quite useful. These use cases don't have any of those, but I'm taking feedback on that, and I think possibly we'll include them in the use cases more generally in future. So that one should be added.
But just to note that in the request, there is information included in the request that influences reporting and result delivery. So we do propose to do that, but not to actually instigate the delivery itself. So the delivery is not part of this spec, but the absolutely in scope is information that is required in the request that will help drive the delivery actually working as appropriate, and particularly things like urgent results and those kind of things. So that information is needed up front in the request.
Thanks, Andy. All right, I'm going to, yes, Dan.
Just back on the practitioner, was there an option there to update service requests? So
no, there is not an option to update a service request.
Instance for updating clinical notes, etc. As discussed last week.
All right, so I'm going to go through the rest quite quickly, and then I'm going to give people some indication of perhaps where to provide more broad feedback if they want to afterwards. So the next one on the list is patient, and we've done very little work around a patient and what kind of use cases they might have in an e-requesting system. This is pretty much as close as we've got, and this isn't even defined as an R1 use case, but I put it in here because we haven't really considered it, the ways in which a patient might want to interact with their own request. So I think this one needs potentially more discussion. And, you know, I think at this point we're at what might a patient actually want to do or have the rights to do under the Privacy Act. Jojo.
I think the guys at the Australian Digital Health Agency might appreciate if there's a request there for the patient to decide whether they want to share their result up to the My Health record. I know that we've been, yeah.
Yep, that is one, and that is actually in the
request
what we're doing at the moment, isn't it? Yep.
Okay.
Should they be able to update it later? You've got here, access the service request. Are you proposing they can edit the service request in the scope of changing their consent?
Well, that's a good question, isn't it? That would
and
appear
to
to be the case.
support the existing behaviour where patients may or may not modify paper requests.
Mm-hmm.
I'd like to think we agree a patient should be able to view their service requests. It gets murkier when we talk about should they be able to edit them in any way.
Yeah, that's another can of worms, isn't it? All right, so moving on to systems. And this isn't going to answer anyone's questions about systems, but there were at least 3 systems defined in the use cases. They were a requesting system, a service provider system, so again, placer and filler style systems. A repository is inferred, and then there are third-party systems that will want to interact with the request, and it's not clear what they are from the use cases. They are variously defined as electronic health record or hospital. They could also be essentially any system with access to data under the Privacy Act.
What about HI services? Sorry, I said, what about HI services? So
yeah,
what would a HI service do, Michael?
Well, you do. Both of those systems would be interacting with a HI service, wouldn't
they? Yeah. Isn't that like the requesting system may interact with the HI service, and the service provider's system may interact with the HI service? I don't think the repository would, and then because they're sort of, you know, the service provider system and the requesting system may interact with all number of systems. Is the HI system something for us to call out? I'm not sure.
I can't answer that.
I can accept that we may decide that it's mandatory to have a HPII or must support. I can accept that. But do we then start including the HI system as a role in e-requesting? I'm not sure.
Well, there is a space for any kind of delegated system. So any system that represents a user that has delegated access or access under the Privacy Act to that user's records could theoretically have access to the request.
I think just from your previous slide, that I don't know quite how to term it, but the patient system or systems operating under the patient's guise.
Mm-hmm. Patient systems. It's very close to what the US allows. Jojo?
What about the transportation or the messaging system? Perhaps the third-party service that the requester, the service provider, and the requesting system uses for the communication. Does
I
that
think
need to be
that's the
considered?
repository in this case. In other words, if it's merely just if it's just message transportation, then it doesn't require an actor. But if it's sitting there allowing data in, data out, then it's kind of a repository.
So existing services like HealthLink would be considered a repository under this model?
Depends on what they're doing.
I can see them playing the repository role. I don't think there's a messaging role here.
Yep. Sam?
Not sure about my health record system needs to be added to this or not.
At the moment, I don't believe we have a use case where my health record is an actor in the sense that
part of the request.
No, sorry,
it's not part of the request model.
No, it's not part of the request. It could be. It could have a repository, but it's not part of the. There's no point at which we push any data to my health record as part of this, or even pull an IHI or do anything like that. It's assumed that maybe that we have those details, but we don't.
Maybe it should be considered unless the patient or the client, the consumer, is able to access the repository and see what pathology requests they have outstanding that they haven't gone and fulfilled. Like, so if there's more than one service request that hasn't been completed or actioned on, maybe is there a way that the patient would be able to access it and see what they have?
Yep. So I think that's what we're trying to cover with this use case, and Angus's note about patient systems. It needs more development, clearly.
Yeah, I can see the My Health Record playing the repository role, like one day. To add My Health Record here as another player, like requesting systems might send a copy there. That's really not part of the process of eRequesting. And My Health Record may want to stand up a repository. That's fine, but I don't quite see how the My Health Record fits in the scope of eRequesting. Like, it's not the requesting system, the service provider, the patient, the act of doing the request doesn't require the My Health Record. That's not to say one of them doesn't send a copy there, or that it plays a role as a repository.
Andy Bond?
I was just going to note that I think we've got to be quite careful here about not having the requesting and providing services begin to have additional attributes with them that we now assume are part of the system. So by that, I mean things like clinical decision support, or even things like checking for existing or previous requests. That all may be done by a requesting system or a providing system. There may be some validation against MBS schedule and all sorts of things. But this is only, I think, the litmus test is where the interaction is involved with the requesting repository or service itself.
So essentially, let's be careful to avoid things that aren't part of the workflow.
Well, that's a hard one because you're talking about an end-to-end e-requesting workflow. From a requesting systems perspective, there's a whole bunch of things they may do in order to get to the point that they can interact with the repository, and that may include clinical decision support, HI service interaction, all sorts of other ancillary stuff that actually just helps bring the e-request into a state in which it can be submitted. But I don't think we want to carve off all possible things that happen leading up to the request being created.
No, agreed. Okay, so when you put them together, they look a little bit like this. So that's the combination of the previous 3 slides. Not necessarily complete, because I was trying to make it readable. You'll notice directed requests are in there. So what happens next with this work? There are 2 places you can go to find it. They're exactly the same place. I recommend if you're interested in going and looking at where I'm at with this work, you go to the short URL, shorturl.at/AQLJ9, capital J9. This will be in the minutes afterwards as well. I'll make sure it's in there. This is really a work in progress. And once I've revised the diagrams that you've seen with the information that you've provided today and worked out how we can go forward with that, I will actually make a Confluence page so it's living in the proper location. But having to spit out the pictures one by one and do them that way is a bit fiddly, so I've done them in Miro first. You should be able to view and comment on that. Please go for your life. We've run quite over time on my session. I do apologise, Andy, but I might throw over to you and hopefully we can get through some stuff in the last 20 minutes.
Could I just say one thing, Chris? Could I get you to have a look at the HL7 firework around actors and what actors are looking to be used for into version 5 of FHIR? There is a particular nuance around the role actors have in conformance. And I think we need to keep that in mind as we define what we mean by actors, because ultimately we're going to start talking about actor obligations, and that's going to then become the foundation for conformity assessment about entities that want to play certain actor roles.
Yep, no, that's good. That's good feedback. I had looked at that briefly and I'd like to explore it more. So I'll get stuck into that, but I might come back to you with a couple of questions actually around that as well.
Okay.
Okay, so we're over to scaffold design options. It's you again, Andy, I'm afraid. Happy to share for this one.
Yes, I am.
Brilliant.
Chris, could you just remind me which 2 we said we were going to talk about?
Yep, so we're doing MHR, consent withdrawal, and communication request urgent result.
Okay. Someone, I guess I can copy and paste that in if you're looking for this. I think this is one of those attributes that's linked off the data model page as well. So if you're looking for this, I think someone's already put it in there. And this is the reference to it. So I think one of the things we've agreed is a need from the start is around representing the withdrawal of a My Health record upload. So this is represented in FHIR as a profile of the consent resource. And this is what's known as R4 consent. R5 consent and R6 is changing a little bit. And in that there is other ways of making these a bit more computable. But we, at the moment, this is our major focus on consent, and we have followed a Canadian pattern of using this. I'm not sure the Canadian example that is available is actually accurate, but ours I think is. What it represents is, when it exists, is a withdrawal of the consent to upload to my health record. So it is one of these FHIR resources that has a reference to the thing that it's about. So the service request that is instigating this diagnostic request does not link to a consent. Instead, consent is the thing that is making the reference. So you see down here that there is a reference at the bottom to the request or the request group. So this is saying for these requests, we're applying this consent, and the consent documents, who created the consent when it was created, these kind of things. And it is then representing withdrawal. If it doesn't exist, then you go with the policy setting, which is upload by default. Does anyone have any questions?
Where's the yes, no flag that says yes or no?
Where is the yes? It's a deny. So this is the policy rule is an opt-in, and you see that down at the provision, the required pattern is deny. So this is denying opting in to the my health record upload. So that's the thing that represents don't do it. The question, my health record would get results upload based on consent. So it would always be receiving, not sending. So we're not in this instance saying anything about, because this is about the report at the moment, not the request. This is not telling you how the upload would occur. It's simply telling the filler that you are or are not, in this case, you are withdrawing from the upload to my health record. If there is no consent withdrawal, then the outstanding policy setting would apply. Now, there is some argument, which I had with a few people, to say whether this should be always present. So you would have the consent existing whether you withdraw or whether you don't withdraw. It'd just be of a different form. But that seemed to be too confusing. And we went with the option that you only include the withdrawal because that is what you're enacting. If you say nothing, it will by default follow the policy setting. Questions? All right. Given the time, I might move on to the other one. Did you say there was Rule 3 exemption?
No, communication request, urgent result.
Excellent. Glad you're here. Communication request, urgent result. Michael Osborne asked this question when we were talking about the use cases, and this is one of the standard set of requests that FHIR supports. So FHIR has service request, medication request, communication request, and for a communication request, you are requesting that a requester, so there's an individual requesting the communication, who is to receive the communication, and who is to send the communication. In this case, this is including a direction to the filler to say, we are requesting you to send a result to in this case, a eRequesting practitioner role contact, which includes details about how to contact the practitioner to deliver the urgent result. And it is a way of enacting an obligation on the filler at the direction of the placer. So normally the placer would be asking the filler to send an urgent result back to the placer. In theory, you could be asking them to send it to someone else. But this could be used in association with a constraint that you can only apply this to a urgent request, for instance. Communication requests are a general thing. So there is also an argument that we could do copies to results in exactly the same way, that we would send a communication request to the filler to get them to send a copy of the result to another practitioner if that was required. But that's a discussion for another day. This is probably a pretty good example.
No fax. No fax medium.
No, sorry. Do you want me to include fax as an option?
It's not as silly as it sounds.
It will need to include fax and it will need to include letter.
Well, urgent result as a letter, or are you talking about as a replacement for copy to?
As a replacement for copy to.
And Michael Osmond, are you talking about urgent result through fax?
It might be a referral or something like that. Could be anything.
But in particular for urgent results.
Yeah.
Yes,
unfortunately.
Yeah, sadly, it occurs to me too that I think I've seen doctors literally request by writing on the form urgent fax. Like it's urgent, but don't call me. Just fax it to me urgently.
Okay, Michael. Put me down for another action to amend the practitioner role recipient on an urgent result to include details of contact via fax.
Maybe the fact should be another system on our system diagram.
Does it? I hate to be the bringer of bad tidings. Does it have a text alternative?
You mean you would like
in other words, if
SMS?
I want to specify urgent results via Slack or urgent results via walking down the corridor and knocking on my door, are either of those two valid?
I'm going to say at the moment, no, but that's solely on my recollection of the value set that you can choose from when coding how you wish the medium of communication to take place. So in here is medium, we've got SMSs, emails, or phone. So in theory, we should support all of them I should add all of them to the practitioner role contact.
And medium that's an example, like in the base standard, it's an example code system. So in the future, a medium could be a system for Slack and like it's extensible. I'm not saying we add it today, but it's.
Yeah, and in theory you could, and then you would just need to create some way of representing those details within some kind of telecom contact.
Mitesh.
I think faxing is like requesting practitioner's preference. It is, we cannot determine that, yeah, we are going to fax it based on the request if it's urgent. It's mainly a preference if that information is available.
Not quite following, Mitesh. What do you mean?
So like if when we get a request, we don't say, yeah, this is the request we are going to fax the result to because it's urgent. We determine that, okay, the referring doctor has said that, yep, my delivery preference is fax, then we will fax it.
But don't you think? Don't you believe we also? So I agree with that mode where we know that this provider likes to have his reports faxed to him. But I think this is more this is no different to a doctor writing on the form, please urgently phone me on this mobile number. But now he's saying urgently fax me the result. So he's overriding his default modes by explicitly for this request instructing you to fax or phone him. I don't think this covers the modes that we have by default that, we've pre-arranged with the doctor that he would like his reports faxed to him is not part of the eRequest. That still exists, but it's not something he restates every time. But he can override it in an urgent sense, like this one's urgent, phone me on the golf course.
Yeah. In that case, we have to acknowledge that and fax.
Yeah. This is the equivalent of literally writing on the request form, urgently phone me on this number.
Yeah.
Okay. So I'll fix this one up too, Michael, and you guys agreed to have an action on looking at consent and how the department sees it being represented. So if you can add that to the action list too. And I think that's me done. If there are no more questions, I'll hand back to Chris to close out.
All right, thanks, Andy. Right. Well, we seem to get through everything in good time. Thanks, everyone. Our next meeting is scheduled for the 23rd and 28th of May, Thursday the 23rd and 11 a.m. Tuesday the 28th of May. Following that, there are meetings on the 6th, 11th, 20th and 25th of June. So plenty of stuff coming up. The minutes will be available shortly after this meeting, and I will ensure to provide some more information on the actors in there as well. We've got 5 minutes remaining. Does anyone have any other business they'd like to cover relevant to this meeting before we finish up? Nope. All right. Thank you, everyone. I think that was pretty productive. There's certainly lots to go on with. So much appreciated, and we'll see you all on the 23rd.
Thanks, Chris.
Thanks, Chris.
Thank you.
Thanks, Chris.
Thank you. Bye.